formally starting the webinar. So again, I'd like to welcome all of you to this webinar on the Decision Guide for Family and Friend Caregivers, being sponsored by the BC Ministry of Health, and we are Family Caregivers of BC. So I'm just going to do a bit of an introduction section here. For those of you who live in British Columbia, we are a nonprofit dedicated 100% to the well-being of family caregivers. And we've been in operation on Vancouver Island for 30 years and have been serving the province as a whole since 2010. And in the last 5 years, we've been part of the Ministry of Health Patients as Partners initiative. And with the ministry's funding, we are able to offer free services and programs province-wide. This is a bit of a busy slide, but basically what we want you to know is that we have 3 main pillars. The first one is caregiver support, the second one is caregiver education, and the third is collaboration and engagement with the health sector. Starting with caregiver support, we have a number of services that you can access from anywhere in the province. Possibly the most important one is our toll-free line. And so you'll see on the right-hand slide, the right-hand corner of that slide, the number is 1-877-520-3267. You can call that number toll-free from anywhere in the province, and you'll be able to speak to one of our staff about your caregiving situation, and we will do our best to help you with information referral, navigation, and emotional support. Cannot underestimate the importance of that. We also have a one-to-one caregiver coaching service for really complex situations. If we feel that you fall into that category, we will refer you to our coach. We'll give you information about support groups that run throughout the province, and also direct you to resources on our online resource hub. In terms of our resources and education, this webinar is a good example of what we do, but we also have on our resource center 2 flip books, one on staying healthy while caregiving, the other one on resilience. They're really great resources for you, and if you're a new caregiver, we have an e-learning module that you can work through to just give you some ideas about where to start and how to keep your own balance as you're moving along your caregiving journey. We post all of our webinars recordings on our website, so this one today will be posted in roughly a week, along with any handouts that we've made available for the webinar. And we also do events and presentations across the province. In terms of our collaboration and engagement with the health sector, what we do there is we represent family caregivers at various health planning and delivery tables. So this is a very important part of the work that we do provincially, and we are always looking for family caregivers who might be willing to become a voice for family caregivers. So if that's of interest to you, you can go on our website and on the tab that says Get Involved. We would love to hear from you because it's a really important thing for us to be able to bring the caregiver voice to health system planning and delivery, and where you're at, and hearing what others are going through. I am just thrilled to be presenting here today Carol Robinson. And for those of you who joined a bit early, Carol was explaining that this has been her passion. She's a PhD in nursing and a professor emeritus at UBC in Kelowna. And for a couple of decades, Carol has focused her research on caregiving because she herself has been a caregiver and understands what kind of challenges that poses in your life. So she and the team developed this tool, and she's going to be explaining that as we move through this webinar. Again, just really appreciate Carol's willingness to do this webinar today. It will be recorded. It will become one of our resources on our website. And I would encourage you as well to check out our newsletter, because Carol wrote an article for our newsletter, which is on the cover of our fall issue, which has just gone out. And yeah, so really this is very exciting for us. I forgot to mention, and Carol asked me to do this, that as we're working through the webinar, if any of you would like to ask a question Again, please feel free to type into the chat box, and I'm just going to show you again where that is. But if you have a question, I'll try to keep my eye. You can raise your hand by just checking off the icon at the top of your toolbar. You see a little person with their hand up. So if you want to get my attention, and I don't see anyone doing that right now, but I will try to be keeping my eye on that as we work through. So at this point, I'm going to change the layout one more time, and Carol will be able to start the webinar, her presentation. And before we move into that, I just want to let you know that you'll see at the bottom of your screen, there are two files that have been downloaded. So one of them is the decision guide, and as well a resource from the BC Palliative End of Life group. So two handouts there that you will be able to download from your computer. As well, they will be posted on our website when we post the recording. So Carol, thank you so much for doing this, and you are now going to be able to present. And do you see where you can move the arrows forward?
I
just
see
underneath.
It.
Right. Perfect.
Okay, I'm going to try the arrow. Let's just see. We're going to talk about the Family Caregiver Decision Guide, folks. I'm delighted that you're here, and I'm very happy to be with you for this conversation today. It's a great pleasure and honor to have had this invitation by Family Caregivers of BC to share this work with you. Before we get going, I want you to practice a little bit about raising your hand. Could you tell me how many of you are currently caregivers by raising your hand? Let's just see.
Oh boy, yeah. So 5 people have raised their hands. 6.
I'm
okay.
wondering if you can. I'm wondering if you can hear me.
We can hear someone speaking.
Yeah, I'm sorry.
Yeah.
I don't have a visual at all on my phone. So I think I'm going to just be here listening by the sounds of things, and I apologize for that. I'm not very technically savvy, so I think I'll just listen and perhaps have a look at the one next week when it's available online.
Yeah. No problem at all. So I would just request that for those of you who are just phoning in, so that we don't get any background interference, if you can press *6 on your phones, that just mutes any background noise.
Thank you.
Perfect.
I see folks are finding the hands up button. It's at the top of your screen, and pretty much everybody is a current family caregiver, it's looking like.
Yeah.
Is that your read, Janet?
Yeah, it looks like 9 people. So that's definitely half of the people here.
Oh, okay, awesome. And now, how do people turn off their hands, Janet? Is there?
I don't know if it. Oh wow, we've gone up to. Yeah, I don't know if it really.
Lot.
Yeah.
Okay.
I think we got up to 15 people there. Thanks everyone for doing that.
And anybody who's not a family caregiver, could you just give us a little write in the chat box about your interest in this webinar? Just so I know who's in the audience, would be extremely helpful. And Janet's going to keep track of that. Yep. So I'm going to start because I have lots to talk about. What are we going to do today? You're going to learn about a national resource for caregivers. It's called a decision guide. And what it does is help identify caregiver needs, whether they be for information, education, or support. And it is meant as a tool that enables caregivers to have focused, clear conversations with trusted providers who can help them answer questions to have their needs met, and to also take stock of where you are as a caregiver. So we've got
a couple of professionals.
Caregiver support trainer, fabulous folks. I think that's extremely helpful for me.
Mm-hmm.
Who am I? You've learned about that from Janet. I'm going to give you a bit about what we've learned about caregivers and caregiving, recognizing that every situation is unique. I'm going to blitz through how we developed the guide pretty quickly, and then I'd like to walk you through the guide and show you some areas where we think there are sticky points for caregivers, questions and discussions throughout, but I'll try and pause, and then we'll close. We have an hour and a half, a little bit less than that, together. So one of the things we're very clear about is that the bulk of illness care is done at home and that family caregivers are responsible for it. You're going to see a word called palliative throughout this presentation, and palliative can be quite a scary word for many people in society. Now, I'm curious about those of you, is palliative a scary word for you?
Yeah, that's a really good question.
Okay, I'm seeing yes. Yes, okay. No for Robin, super. And a comfort for Mary Ellen. All right, a lot of whether it's a scary word for you depends on your experience with it and your beliefs about what it means. So I'm going to tell you about what I mean when I use the word palliative, so that hopefully when it appears, it isn't going to be scary for you. By palliative, I mean care that focuses on quality of life. I don't mean care that is solely focused on death, dying, or end of life. That's where it gets scary, where people think, okay, if I'm going to consider palliative care, it either has to do with death, dying, or end of life, or it means care that's inferior. This is not the case when I'm speaking about it. The palliative community thinks of themselves as assisting with quality of life issues beginning very early in the illness experience and happening alongside with illness or disease care. So that's what I mean by palliative. And the other word I want to talk to you a little bit about is family. Family for me means whoever the ill person says is family. And a family caregiver can be many different kinds of persons. It can be partners, it can be spouses, it can be children, it can be parents, it can be dear friends. So many people fulfill this role. And it's meant to be inclusive of whoever is acting as a caregiver to someone who's ill. So we don't want to exclude anybody in this work. We know that your work is critical. We know that our system depends upon it. We've done lots of studies, so we understand the experience quite well, but we don't understand how to support quite well. Somebody's having trouble hearing.
Yeah, and I don't know if anyone else is having that trouble. I'm certainly hearing everything very clearly, but if anyone else is having that trouble, can you let us know?
Okay.
Yeah, okay. I don't know what to suggest. Yeah.
We've done many studies with family caregivers. I'm going to speak up a little bit and hope that that may be helpful. Most people talk about taking the job up automatically. Of course, they don't think of themselves as caregivers. It's something that we do for the people that we care about. So they don't view it as a decision point. And this has been interesting throughout our studies, is that many family caregivers don't see that they are actually making decisions all the way along. Often don't know what they're getting into, sometimes afraid to ask for help. I'm going to explain that a little bit farther along. Often not well prepared and not well supported. Sometimes there's a promise, sorry about that. We have talked in a research study to bereaved family caregivers who believed they had made a promise to care at home until death, and their ill person did not die at home. And we were very interested in understanding that experience and what got in the way of a desired home death. What we found is that their promise was challenged by lack of preparation, really strong difficulty accessing support and information in a timely way, and deep frustration with the inadequate help that they received. As a consequence, what we found about this promise is that it constrained decision-making, that the promise to care at home until death actually closed people's options for considering other ways and places of providing care, and that it pushed these folks, under the circumstances of not getting the help and support they needed or preparation, to go beyond their own abilities in providing care, pushing themselves beyond boundaries, and compromised their ability to provide care. They all hit a bump in the road where they called healthcare professionals, which they'd been advised to do, and were told to bring their ill family member in, and their ill family member didn't come home. One of the things that they weren't aware of is how close their ill family member was to dying. And the broken promise had very big consequences for these folks. Strong, persistent guilt, a sense of having betrayed a promise, and a persistent sense of failure. So it really affected the quality of life of caregivers over time. We wanted to find out, what about family caregivers? What is it that family caregivers need in order to care at home the way they want to care? And this study honestly baffled me. I was expecting, when I asked the question, what do you need to get personal needs of the caregiver? For example, I need to get out, or I need to get a break, something that is personal. What I heard was something quite different. What family caregivers need is to be excellent caregivers. So they need to be skilled to know more. They need to navigate competing wishes, needs, demands, and priorities, and they need help doing that, and they need an extra pair of hands for doing things that are particular. It was important for these folks to know, they said it's important to know the goal of caregiving. These folks, their goal was to care at home for as long as possible. And so this goal was markedly different than the people who participated in what I'm going to call our promise study. They wanted to care well at home for as long as possible. They were open to the idea about caring at home until death, but they weren't saying that needed to be the outcome. And this was very helpful to them. It didn't constrain their decision making. They also had a goal to be as close to their ill person as possible. And I'll explain a little bit what that means as we go along. They were determined, just the way the folks in our promise study were, to care at home. But we learned that determination is necessary but not sufficient to enable successful caring at home. And there are 5 factors that I'm going to talk about. The first is initiation of formal palliative care. So we have this very recent study done in cancer care where they trialed starting palliative care early along with disease care for one group of people and then just regular care for the second group of people. And the outcome has startled us. The folks who got early palliative care actually had higher quality of life, as did their caregivers. That part wasn't startling, but they lived longer than the folks who didn't have early palliative care. What does it do for caregivers? What our caregivers told us is that the system recognizes the caregivers and recognizes their value. They had access to a highly qualified team, better coordination of care, and high availability of a program of resources. They talked about having someone thinking with them so that they weren't alone, and often talked about how wonderful it was when things suddenly appeared, like a hospital bed. They might not have needed it at the moment, but when they needed it, it was there. So, initiation of formal palliative care, having somebody else with you. Asking for and receiving help. What we learned from the folks in the PROMISE study was that they were often afraid to let the healthcare providers, even if they had palliative folks coming into the home, they were afraid to let the healthcare providers know that they were struggling. And their thinking there was that if I tell you I'm struggling, you might think I can't do this, and you might take caregiving away from me. Whereas the folks in our second study who actually, all of them achieved a desired home death, said, I ask for help. I tell people when I'm struggling, and then I receive it. So asking and receiving are two different things. Sometimes the receiving comes when you have somebody thinking with you, like, for example, a community nurse who might say, gee, you know, I think you're getting to a place where you might need a wheelchair or a walker. And some people, often caregivers, use the strategy of one day at a time, which really puts a few blinders on decision making because it's hard to lift your head and look forward. Whereas the person thinking with you can do that and perhaps put things in place in advance. That's the receiving help bit. Augmented care. You cannot do this alone. So what happened for these folks was that they not only had a healthcare provider on their side, but they had family involved. And they talked about getting assistance with care, not only from family, but from the ill person themselves. I don't know if any of you are in this situation, but sometimes the folks who are ill have trouble accepting care and receiving help. And what these caregivers told us was that there were a couple of things that the care recipient did that were extremely helpful. If they could maintain their sense of humor, and if there was gratitude for what the healthcare, the family caregiver was providing, and when they did as much as they could to help themselves. So augmented care is particularly helpful because it can be timely. One woman explained to me that she would take her ill husband out for drives, and one day they arrived back home and there were about 4 steps up to their front door, and he looked at her and he said, you know, I don't know if I can get up those stairs. It was the first time he had said that to her. She immediately called her son, who lived nearby, and within 24 hours he had built a ramp. So this idea of accepting a particular kind of care. Relief or respite. Getting a break from caregiving. These folks taught us that often relying on the professional system didn't work for them, that respite outside the home was challenging, and this is also where families stepped in, where the family caregiver who was primarily responsible could get out of the house. One husband talked about belonging to an organization where he felt particularly supported. It wasn't a caregiver support group, but for him to get to the meeting once a month, that was really a critical relief for him. And a family member was always scheduled so that he could do that. So planning and scheduling relief or respite and the involvement of family, very helpful. And then remember I told you there were 5 things. The 5th thing was making the healthcare system work for the ill person. Just say no. These family caregivers were impressive advocates for their ill person. And some of them talked about doing battle with the healthcare system to get what they wanted, or actually more important, what they and their ill person needed in a timely fashion. And others talked about just saying no. So when I think back to the PROMISE study, what happened was, I'm going to give you one tiny example. An elderly woman was caring for her very elderly husband. They were frail. He was approaching end of life and getting quite weak, and reached a point where he couldn't get himself out of bed and to the toilet. And so he became incontinent in bed, and she was changing sheets day and night and really pushed beyond her ability and well into exhaustion. She was advised by a home care nurse who was coming into the home that when she got to that place to call them. She called, and the immediate advice was, you need to bring your family member in. Pardon me. She did, and as I mentioned, her ill husband died away from home, and it was extremely troubling to her. If she had said no, like the folks in our second study, no, I won't do that, you need to figure out how to help me with my problem at home, there is a simple solution in my mind to that particular problem, and it's the placement of a catheter, which can be done in homes. So what the folks in our second study who really managed well at home until they were ready to relinquish caregiving at home, and in fact all these folks managed to caregive at home until death, they said, no, you need to figure out how to help me at home. So those are the 5 factors, all things we learned. The other thing we've learned in all of these studies is that there's a dilemma in supporting family caregivers. There's a right way and there's a wrong way. Family caregivers told us that they don't like it when the focus changes to them versus their ill person. They want all of the focus on their ill person because they fully understand, especially for paid healthcare providers, that we're busy. So they don't want to divert attention. While they are happy when we see that they're tired or that they need help, one of the most common ways that healthcare providers respond to that, seeing things about the caregiver, is to acknowledge it and then to give the caregiver another job, to look after themselves. So often it's, I see you're getting really tired. How about taking a break? How about getting yourself out of the house? So we give caregivers another job, and we don't recognize the goal of staying really close to the ill person, and we advocate moving apart, which doesn't work well. And then, of course, you've heard that some caregivers are afraid to tell us. So we have this dilemma about how to do it right. We asked this question of ourselves. We knew that the push now is to develop interventions, including resources. What could we do that might be helpful? Well, if caregivers aren't well prepared or educated, we needed to take that into account. If we knew that, as we did, that some choices close options, we needed to create space for people to consider many options. Home, people often have a belief that home is the best place to be, even unto death, and yet that's not always the case for either the ill person or caregivers. And we also knew that family caregivers didn't see decision points. So we needed to help decision making, but we needed to do it over time because caregiving changes. So we decided to develop a guide that we wanted to be flexible, could be useful no matter where you live, no matter who you are as a caregiver, that covered enough but not too much and was easily understandable. This is what the early versions looked like.
Carol, I'm just going to mention that Kathy has put up her hand. And Kathy, I'm not sure if you have a question that you can type into the chat box. Oh, okay, so she's now put her hand down. So please feel free to type into the chat box. It's the easy, we have quite a few people in the webinar, so for me to unmute people is a little bit of a challenge. So if you can, type your question and I will definitely make sure that Carol sees it.
Awesome.
All right, sorry, Carol, go right ahead.
Okay, I see a couple of people typing, so this is perfect. I'm really happy with this process. Can I please re-show the last slide? Yes. I'm showing you this slide because we got very particular feedback about the look of this early version. It's not meant for you to take in what it's saying. Okay, so where we started was with bereaved family caregivers because we didn't want this process of developing the guide to be overly burdensome for current family caregivers till we could figure out, did we have something that was pretty usable and did we have something that wouldn't cause harm? Those were my two big worries. So we went to bereaved family caregivers and asked them to work their way through an initial version of the guide and then to talk to us together in what we call a focus group. And what we learned was absolutely interesting to us. So they said, I'm going to give you the feedback on what they saw in the guide. They thought it had potential. They thought they had lots of problems with how it was organized. They didn't find some of the language helpful. In fact, they found some of it difficult and inappropriate, and that was the language that shifted the focus to the caregiver. They said, don't do that, please. Remember, they were bereaved family caregivers. Their ill person had died. They wanted us to be very explicit with our end-of-life language and our death and dying focus. We were worried about that because we thought that advice might be particular to their phase in the caregiving journey. So we held back on doing anything about that. So despite the potential, they gave us lots and lots of feedback about how to make it better. They said, and you know what? It looks like a tax guide, and we would not pick it up and use it. That was new learning because we were using there are international standards for the development of decision aids, and they don't include aesthetics. So one of the things was that we redesigned it, and this was the new cover page, so that it looked much more friendly for our next round of evaluation. We began to pilot it with family caregivers that were actually using it, and we wanted to put it into practice with support. What did we learn? They thought it was useful. They thought, and this is really important for how we go from here, it needed to be introduced really early in caregiving. So when we talk about palliative and palliative beginning at the diagnosis of a serious or life-limiting illness, we're talking about way back then, used lots of times as the condition or the caregiving situation changes. They talked about getting it way too late, and we've experienced that a lot through each phase of the research. And they found that it always raised questions. And the guide helped them do that. So really what we've learned, and you're going to hear me say this over and over, the guide is not standalone because it raises so many questions. It's the tool that helps the conversation for caregivers to get the support they need to carry forward doing the caregiving work they want to do. It can be used all sorts of different ways, in pieces, all at once, or with support. But you need information about local resources. And Janet's inserted a helpful slide towards the end about local BC resources, because the guide itself, it's national, it only has national resources in it. So what I'm trying to tell you is it's all about the conversation that as a caregiver you have with yourself as you're working through the guide, the conversations that the guide may help you have with your ill person, and then the conversations with healthcare providers whose job it is to support you and your ill person. All right, I'm going to pause here before we begin to walk through the guide for questions.
Yeah, so if anybody has any questions, Kathy, this would be a great time if you would like to type into the box, or anyone else for that matter, if you have any questions.
All right.
I see one person typing in, Carol.
I do as well. Multiple attendees are typing. Okay, while people are typing, I'm just going to comment. You will see that the cover of the guide is again different. After that last study, we professionally redesigned the guide, and we did an implementation study where we used it in practice with support in a rural and an urban setting. And we learned something very interesting. Thanks, Mary Ellen. The comment about ill person, not loved one. We really learned that from caregivers. There are so many reasons that people provide care, and love is only one of them, and may not be the predominant one. So yes, ill person. Is the decision guide currently being? No, it isn't in use by community home care nurses that I'm aware of. It's in use by some hospice palliative care associations in BC through volunteers. That's one way we actually trialed it. We trialed it in a rural community with volunteers from the Hospice Palliative Care Association, and their job was simply to sit beside the caregiver and help them work through the guide, identify their priorities, and then connect them with the resources or the answers they needed. It worked beautifully. So it's in use there. It's been translated to Portuguese, and it's in use throughout the whole of Portugal via their Palliative Care Association.
Oh, someone wants to
Can
know.
you purchase them? You don't have to purchase them. They are free online. You can see there's a URL there. There's information at the end. We've now developed an interactive website where you can work through the guide interactively and then print your answers. Or if you prefer to work on a paper copy, you can download and print a PDF and record your answers on paper. All right, I'm going to keep moving if that's okay while we're waiting for more questions. All right, this is the inside cover, and it's a reminder that the guide is meant to be used over and over and over again. Caregivers have some trouble understanding that. They've kind of thought, if I go through it once, that's it. But the thing about caregiving, as you may very well know, is that things change. Sometimes caregivers get ill. As the illness progresses, the needs of the ill person change. Sometimes there's things totally external to the relationship between the ill person and the caregiver that have an impact, like other responsibilities. Often caregivers are sandwiched between parents and their own children. There's lots of things that change caregiving. So it's meant to be used over and over again. One of the recommendations is that if you do use the paper version, that you fill it out in different colors of ink each time you use it. If you use the online version, you can print it after you've completed it and then note on it what the date is. And then when you go back at a later date, you'll be able to compare your answers. One thing that we found is that, of course, with this strategy, and it works very well for caregivers, of one day at a time, you often lose track of how things are changing and slipping for you. So if you look back at a previous time when you've done worked through the guide, you may see, much more clearly that things have changed. This is the second page, and you'll see that the guide is organized around a 4-step process. So you think about the situation now, you think about how things might change, you take a look at the options in terms of resources and support, and then you consider, what are my best options now or in the future? This is step 1, thinking about my caregiving situation now. You can see that there's 2 columns. I don't need help. I could use some help. Of course, the answers change as the caregiving situation changes. We've got some pretty straightforward things like house maintenance, car maintenance, but remember I was going to tell you some of the sticky bits for caregiving, and you may be, okay.
We have a few questions, Carol.
Sorry?
Oh, I was just going to, I noticed that you're looking at the screen. There are a few questions that I've been saving up. So One is,
Okay.
are you linked in any way with the UBC Okanagan NavCare research program?
Yes. The NavCare research program uses this guide as an option.
Great. Then Dustin says, would you recommend this tool for families where there is conflict or very complicated relationships, i.e. blended families?
Yes, I would, Dustine, and I'm going to show you a section where this will actually come up, because the family caregivers in situations where there's high conflict or complicated relationships often need professional, and by professional I mean healthcare provider assistance, navigating competing wishes, demands, beliefs and values. So I'm going to show you where that comes up in the guide. And how does this relate to the representation agreement? This is not a rep agreement, but I'm going to show you where in the guide this might come up, and it might highlight the need for a rep agreement. For example, for those of you who don't know, a representation agreement is a legal document that is BC specific, that talks about designating someone as the decision maker for the ill person if the ill person is unable to make healthcare decisions for themselves. And in a family where there is conflict or very complicated relationship, I advocate a representation agreement because it makes it very clear who is the responsible decision maker should the ill person not be able to make decisions for themselves, which is not an uncommon situation towards end of life. You okay with that, folks? Okay, I'm going to move on. Sticky point here in this think about my caregiving situation now is personal care. In all of our studies, family caregivers, regardless of relationship, unless it is wives caring for husband partners, are concerned about personal care for their ill person, and would say that when they begin providing care, that when their ill person is unable to toilet themselves or is experiencing incontinence of bowel or bladder, they would like that managed by a healthcare provider. Where you come into a sticky bit is if you want to provide care at home for as long as possible, providers are in and out of the home, and your ill person may need personal care when a provider is not available, and so most family caregivers bump up against the need to provide personal care because it's what's necessary in the moment. So it's the I wouldn't say conflict, but it's a bump against caring at home for as long as possible and not wishing to provide personal care. And which one is the one that becomes the primary thing that you want to do? Here we move on to how am I doing with managing things like pain, symptom management, spiritual care, knowing when something needs medical attention, and then these are how confident am I with. And this actually is a helpful thing to look forward to in terms of the future. Understanding the illness now, and it's about change. So it's opening the option that things may change, and you might need to prepare for them. Would you want to know how this illness might change? What might I expect? Maybe not now, but maybe in the future. Would I want to know about my family members' wishes for care towards end of life? Here's where goals of care, advanced care planning, resuscitation orders come into play. People often think that this idea about advanced care planning is an end-of-life thing. And I say no. It's just like the guide. The earlier the better, and then you revisit it over time as things change. And this is where a representation agreement can be part of advanced care planning, particularly in the circumstance of complicated family situations. And then this X. How well am I managing now? This X on the line is a real indicator over time. When a caregiver fills this in, you can look at it like, oh, I filled this in a few months ago. I filled this in 6 months ago, and I was doing pretty well, and look, it's slipped a bit. It's an indicator of how you're doing. And then what about your own health, your own well-being, so that you can best care? Do what you need to do. Here are, I'm doing okay, or I could use more of this. And it includes time, breaks, and various kinds of support. So that's step one. It's the blue part. And what I recommend to people, once they've finished step one, check the places where I need this, I could use more of this, and figure out what the priority is. Where do you start? What thing would make the most difference? And I recommend finding your top 3 priorities. And those are the things you can focus on in your conversations in terms of your needs. Step 2. So thinking about how things might change either now or in the future. This question of, have I thought about the choices I might have to make? Yes or no, raises this idea that there are decisions to be made. And then the second question relates to the promise. What would tell me that I cannot keep caregiving at home any longer? And you're going to shake your heads, but the one thing we missed and that our caregivers helped us with as we moved forward was exhaustion. We didn't have that in the list, but that is one of the most common things. People often have mixed emotions about living in the home after death. So there are things that would say, I have a boundary around this, that healthcare providers need to know to be helpful so that they can plan forward. Now, every decision is values and beliefs based. So this next portion of the guide is, what are the things that influence me about caregiving? What are the values and beliefs? And again, you might tick a whole bunch of them. Beliefs about what is right. Desire to spend time. The big one that I am always on alert for is a promise, because you know that we've learned a promise can really create difficulties. I'm not going to go yet to Dustine's question. I see that it exists, but I'll try and get to it in when I'm at the end of this section. So again, there might be a bunch of things influencing you, and if they are, try and prioritize them. What's the biggest influence? And then, what things influence my family member when it comes to making choices about their care? We haven't advocated explicitly for family caregivers to talk with their ill person. This is a subtle request to begin this conversation about what's important to you. When I worked with caregivers of persons with dementia, often again the guide came to them too late and they said, oh, gee whiz, it's too late. My person is too compromised cognitively to have that conversation. And I said, it's not too late. It's never too late. You know your person. You know your person well. What, based on what you know of who they are, would have been important to them? And we ask this because this is an influence. You as caregivers may already have experienced that healthcare providers will often ask the ill person about what's important to them and often not ask the caregiver about what's important to them. And sometimes there are differences. Sometimes what's important to the caregiver is different than what's important to the ill person, and sometimes they're in conflict. And what caregivers tell us is they will choose to prioritize what's important to their ill person, even at risk of their own health and well-being. This is part of navigating competing desires and preferences that a healthcare provider can help. And then this question, who else is involved in caregiving for my family member? Who is this person and what role do they play? Now, when I was a clinical nurse specialist with the Cancer Agency in British Columbia, I was a palliative pain and symptom management specialist. We would talk about the difficult situation with the lawyer's son jetting in from LA. And I experienced it personally. It wasn't a son, it was a daughter. It wasn't from Los Angeles, it was Toronto. Jetting in for a consultation where we asked the question, okay, now what's your goal for caring at home, to the elderly wife of an elderly man with cancer. And we asked about how long caring at home for this couple, and daughter piped in saying, of course my mother will care at home for my father, and of course my mother will care at home until my dad's passing at home. And then she jetted back to Toronto, and Mom was on her own. So we need to know about the influences and the pressures, if you will, in order to help navigate these aspects of part 2. Now, we've ended part 2 where we looked at what is influencing decision making. Let me just take a quick look at questions.
I think a couple of questions were about whether or not there is education available in terms of personal care. And I don't know.
Okay.
Yeah.
Yes. Now, in an ideal world, there's education from community care nurses. If you are providing home care at home and personal care is required, I would hope that you are connected with community care. So there, in the best world, there's support there, and often there is support where care aides can come into the home. Some family members, remember in the just say no part, found that untenable because they didn't know when the person was coming in, and the person changed from day to day, which didn't work for them or their ill person. So they just said no and did it themselves. There are wonderful guides on the Canadian Virtual Hospice Society site, which gives some ideas. One woman who I spoke with said, I'm even afraid to move my partner because she hurts so badly when I move her. I need help knowing how to move her. So these kinds of things, you're right. You may not know, you need to know until you get there. And if that's the case, and you're not, you don't have community or home care resources, talk to your family physician. That's your go-to. Okay.
Terry pointed out.
Yes, go ahead, Janet.
Terry just pointed out that community hospices have trained volunteers who do workshops around caring for people at home. I think she's from the Comox Valley Hospice Society. I recognize the name, Terry. And you had mentioned, Carol, about Canadian Hospice, Canadian Virtual Hospice. I will include links in my evaluation email to everybody attending, because they have some wonderful videos around personal care if people don't live in a community that has a hospice society or anyone else that can help them with that.
Yes.
When she's saying also advanced planning, yes.
Yes, and the question, do I ever think Canada will adopt education programs? I think it's trickier than England because this is a provincial responsibility, not federal, and every province deals with it differently. So in truth, Dustine, I don't know. Okay, so to recap, we've looked at what's happening with caregiving now and what might you need, what influences decision making. Now we're looking at what are the options, resources available. This was a fascinating part of our implementation studies, because even in small rural communities, caregivers didn't know what was actually available to them or how to get it. And over several studies, we found that caregivers think that things will be available to them at the moment they need them. And often this is not the case. For example, caregivers who go beyond their own personal resources providing care and decide, okay, now's the time that I can relinquish care, providing care at home, and I'm ready for us to move into some sort of professional facility to provide care. Sometimes it isn't available at the moment that you need it. So this idea about thinking through what might be available and then talking to a knowledgeable person about what actually is available, and is it, under what circumstances is it available? How much lead time, for example, might you need? That's the third bit for decision making, because often providing care at home is very dependent on the resources that will support you. And then that moves us to the fourth step, which is deciding what do I think my best options if the needs for caregiving change. And we've given three options: caregiving at home with increased resources, home with respite away from home. For example, there are often palliative beds, even in rural communities. Those might be in an extended care facility where the ill person might be able to go and receive excellent care so that the caregiver can replenish their resources. Those typically need to be booked in advance, or a healthcare facility, and the healthcare facilities vary depending on where you live. It could be a hospice, it could be an extended care facility, it could be a hospital, it could be an extended care facility. So the caregiver, we're asking the caregiver, you, to think here, and then we're asking you to consider, what does the family member feel about these options? I was telling you, when we implemented this study, one family caregiver said, you know, I think this is just what I need to begin having conversations with my ill person. So I left it right out on the coffee table so that she would see it and then begin to ask me questions, because I don't know how to open the door to the conversation. There's all sorts of strategies to begin to have these conversations. We've added 2 questions. Considering everything I know, what's my best option for caregiving now? Because sometimes once people work their way through the guide, they realize that they need some changes even now. And then what am I thinking for the future? And to have that conversation with a healthcare provider, so that if you've got a future idea in mind, the likelihood of it actually being available to you gets stronger. Pardon me, I'm just going to have to cough. So that ends the working part of the guide. And then what happens after that is pages where you could keep track of your questions. There's a page where you can keep track of important people and numbers. Often caregivers pull that out and put that on their fridge. And there's several pages of national resources. I was mentioning to you that it's now available free in two ways. An interactive guide, which is at this www URL, and it allows you to work through the guide, make your choices, and then print with your answers. Or again, within this website, you can simply, if you go to resources, you can print off a version of the guide.
I would just like to say thank you to Carol so much for the presentation and helping us learn more about the guide. I think Dustin put